To jump into our program for this day. We're really excited to have a special guest online here with us. We want to thank all of you for kind of going with the IOMC and switching over to this virtual programming platform. Indeed, I hope it offers us a chance to engage more of us um, because of its accessibility. So the theme of our meeting today is honoring healthcare heroes, and we're fortunate to have as guests two leaders who fit that bill, even if they don't wear scrubs every day. Senator Dick Durbin is well known to many of us. Senator Durbin was just reelected last month to his fifth term representing Illinois in the United States Senate. He is also the Senate's Democratic whip, making him the second most powerful Democrat in the US Senate. He is widely regarded as one of the Senate's most gifted speakers. He's also one of the senators you are most likely to find at the center of any bipartisan effort to solve really tough problems. To cite two current examples, Senator Durbin is a key player today in bipartisan negotiations to pass the next COVID relief package, as well as a plan to fund the US government after its legal authority to spend money expires 1 week from today. Senator Durbin also serves as a Democratic whip, the second highest ranking position among Senate Democrats, and he's been elected to this leadership post by his Democratic colleagues every 2 years since 2005. He was elected to the US Senate on November 5th, 1996, and he fills the seat left vacant by the retirement of his long-term friend and mentor, US Senator Paul Simon. Senator Durbin sits on the Senate Judiciary, Appropriations, Agriculture and Rules Committees. He is the ranking member of the Judiciary Committee's Subcommittee on Immigration and the Appropriation Committee's Defense Subcommittee. He is here today to talk a little bit about the pandemic, the importance of medical research, and an innovative effort that 10 leading Chicago hospitals have launched at the senator's encouragement to improve the social determinants of health in Chicago's neighborhoods, struggling with high rates of poverty, joblessness, and violence. It's called Chicago Heal, HEAL, and you can find a link to it on to its first annual report on the Institute of Medicine Chicago's website. When we asked Senator Durbin to join us, he accepted quickly. We really do thank him for his support over the years. He then asked, would it be okay if I bring a plus one? And indeed, Dr. Collins is on the line with us today as well. It's a rare opportunity to engage a person that I and many others hold such deep respect for with his scientific work and leadership. Dr. Collins was appointed as the 16th director of the National Institutes of Health in 2009 by President Barack Obama and confirmed by the Senate. On June 2017, President Trump announced the selection of Dr. Collins to continue to serve as the National Institutes of Health director. In his role, he oversees the work of the largest supporter of biomedical research in the world, spanning the spectrum from basic to clinical research. The NIH is a mega powerhouse of scientific research known to many nationwide and worldwide. Dr. Collins is a physician geneticist noted for his landmark discoveries of disease genes and his leadership of the International Human Genome Project, which culminated in April 2003 with the completion of a finished sequence of a human DNA instruction book. He served as director of the National Human Genome Research Institute at NIH for 15 years from 93 to 2008. Before coming to NIH, Dr. Collins was a Howard Hughes Medical Institute investigator at the University of Michigan. He is an elected member of the National Academy of Medicine and the National Academy of Sciences, and he was awarded the Presidential Medal of Freedom in November 2007. He received the National Medal of Science in 2009, and in 2020, he was elected as a foreign member of the Royal Society and was also named the 50th winner of the Templeton Prize, which celebrates scientific and spiritual curiosity. We are very much honored to have the experience of these two leaders with us today. Welcome, Senator Durbin.
Thank you, Dr. Whitaker.
And welcome, Dr. Collins.
Thank you very much. I'm happy to be Senator Durbin's plus one for this discussion. Been looking forward to it. So yeah, thanks for the invitation.
Well, we know the time will fly quickly today. have a few prepared questions, want to kind of walk through here with you guys. And then, of course, as other topics come up, let's discuss them. We'll man the chat. But there's so many topics to talk about today. Um, so, Senator Durbin, I kind of want to start with you, just given the kind of robust political environment that we're in right now. There's a few sort of big things going on, and there's movement this week that makes, I think, many of us excited. Can you talk to us a little bit about the sort of bipartisan effort that is kind of being discussed right now to provide relief to families due to COVID-19?
Thanks a lot, Dr. Whitaker. And let me tell you, my role this morning is to be very brief and to defer to my guest. We're all here to hear Dr. Collins tell us some of the most important things relating to this pandemic. So let me be as specific as I can and give the stage to Dr. Collins as quickly as I can. There's a group of 8 of us, 4 Democrats, 4 Republicans in the United States Senate who've been working for weeks to develop an alternative COVID relief package. The last one that was passed in Congress was on March 26th. It passed the Senate by a vote of 96-0. It was known as the CARES Act. It was over $3 trillion, a huge bill. And of course, it was necessary, not only for the pandemic, but also for the state of the economy. I think it's done many positive things. We believe it needs to do more. The new bill, $908 billion, the one we're working on a bipartisan basis, does several key things. First, it provides an extension of unemployment benefits. On December the 26th, the day after Christmas, 12 million Americans will be purged from the unemployment rolls. They'll no longer receive payment. We changed that. We start the payment retroactive to December 1st, all the way through the month of March in 2021. Secondly, there's help needed for businesses across Chicago and the nation. The PPP program is extended. Third, and very important for Illinois, is help for state and local governments that have lost so much revenue because of the state of the economy. On the medical side, there is money for hospitals and clinics, and equally, if not more important, distribution of vaccine, as well as testing and tracing, which I think are critical elements. There are many other parts to it. I won't dwell on them. I'll tell you where we are politically. We, I think, can reach an agreement maybe as soon as this weekend. We have 1 or 2 really important outstanding issues, such as the issue of liability under COVID-19 world. But I think we're driving toward a conclusion that can be brought to the floor of the Senate as soon as next week, which I think is absolutely essential. We're getting too close to Christmas, too close to the end of the year to waste any time. The second thing is we have to pass our spending bill for the rest of this year. It expires on December the 11th, and our calendar year goes until September 30th. I think we're close on that. I hope we can reach an agreement. It has to be bipartisan. Included in it, I hope, will be a continuation of added funding for the National Institutes of Health. 5 years ago, I visited with Dr. Collins, and we talked about what we could do. Could we return to those days when Congressman John Porter, our beloved friend from the North Shore in Illinois, as well as Specter and Harkin, doubled the budget for the NIH? Well, we set on that task to see the best we could do with the help of Senator Blunt, Senator Murray, and the retiring Senator Alexander. We've seen a 38% increase in NIH spending in the last 5 years, a dramatic increase, and it couldn't have come at a better time. Some of the research, I hope, Dr. Collins will indicate that we did in this 5-year period is serving us now as we develop vaccines and therapeutics. The last point I'll make is the HEAL initiative. I want to salute the 10, I think all of them are on board for this meeting. The 10 CEOs of the major hospitals in Chicago came together more than 2 years ago and decided to reach beyond the walls of their hospitals to the neighborhoods and communities nearby to deal with these health disparities and to deal with the need for economic development, to fight trauma, gun violence, and all of the things, the chronic diseases that affect these neighborhoods. What a remarkable group of individuals. I thank them for their leadership in this, and we're going to continue to work and complete this project. Thank you, Doctor.
Thank you, Senator Durbin. Any thoughts on the fate of the ACA and the case before the Supreme Court? Any thoughts there? I mean, the reports have been somewhat promising, but just any insight or thoughts from you there?
Well, I just don't know the answer to that. You know, we put a new justice on the Supreme Court, Amy Coney Barrett from the 7th Circuit, which includes the state of Illinois. She was at Notre Dame Law School. She's now in the court. She is conservative, that's for sure. but we don't know if that means that she's going to rule against the Affordable Care Act. We spent several days in the Supreme Court hearings asking that question 100 different ways, but we never quite got the direct answer we needed. So we only have to wait and see what happens. The oral arguments to end the ACA that took place already just a couple of weeks ago gave us a positive indication. But if you've been around the Supreme Court at all, you know that you don't want to project the outcome of these cases on the questions that were asked by the justices. It is critically important that we see this extended. The Affordable Care Act provides help to millions of Americans, even millions in the state of Illinois. And we've got to give them basic health care in a time of pandemic.
Indeed. Thank you so much, Senator. And we're going to encourage you to sort of be a part of this conversation as much as you like. So thank you so much for that kind of briefing and introduction. We really appreciate it. Dr. Collins, welcome to Chicago. Welcome to Illinois, because I believe you're probably beaming in all over the state of Illinois.
It's great to be with you, and hello to the Institute of Medicine Chicago. And thank you, Dr. Whitaker, for your leadership of this effort and also for the scientific work you have done. I know you have been an NIH grantee. We're proud of that.
Well, when I heard, we confirmed that you were coming, I said to someone, I said, Dr. Collins he's kind of like my Beyonce. If you're a scientist, when I was in my 30s, and that was 20 years ago, I was indeed an NIH researcher. I was funded. You had opportunities for young researchers to sort of tag along to an R01. And I did that with Linda Powell, who's over at Rush doing huge kind of population-related studies. And I attended an NIH Summer Clinical Trials workshop for 2 weeks. I did clinical reviews for the NIH. So I want to thank you for the opportunity to really strengthen sort of my experience with the scientific method. As I sort of do my work now, the scientific method's critical, right? Science is really where it's at.
If you really want to know whether something works, that's the only way you're going to find out. Just having an opinion is not going to cut it.
There you go. So, Dr. Collins, the NIH is right at the center of kind of the US response to the COVID-19 pandemic. And the hero of the day, one of the heroes of the day is messenger RNA, right? Who would have known it? DNA, its big brother, gets all the attention, and what do you know? Messenger RNA saves the day. Can you talk a little bit about kind of innovation with mRNA and vaccines? I'm really sort of fascinated by that new kind of strain there and that new kind of opportunity.
I would love to talk about that. And it gives me an opportunity also, and I'm going to start with this, to give a shout out to my friend, Senator Durbin, who's been such an incredibly strong supporter of biomedical research and the NIH and its role that we can play in that. And I think what you've seen about messenger RNA is something that Senator Durbin knows well, is that when you want something to happen, like in a pandemic, you probably don't want to wait until the last minute and then make something up. You need to invest over the longer term in a strong foundation of basic science that leads to new ideas, that leads to what you'd call translational research, and ultimately to clinical trials. If we had not invested in this messenger RNA approach for the previous 7 or 8 years at NIH, it would not have been ready at this moment when COVID-19 emerged out of Wuhan, China. And so there's a story there as well. Senator Durbin mentioned the conversation we had 5 years ago about what would be the most encouraging, productive kind of approach for NIH's resources, recognizing that wonderful doubling we had. And I'll also give a shout out to John Porter, as you did, Senator. And I noticed that his son is listening in and was glad for that. So here's a second shout out for John Porter. And that doubling we had from 98 to 2003 was fantastic. The unfortunate side of it was then things kind of stopped, and we went into this period where we actually began to lose purchasing power. And over the course of the next 12 years or so, lost almost 22, 23% of purchasing power to inflation and some horrible things like sequestration. And it was Senator Durbin who really, I think, caught the imagination of the rest of his colleagues about what the right thing to do is with this idea of let's go with inflation plus 5%. That is exactly the kind of trajectory that really nurtures biomedical research, where you have some sense of stability, where you can take risks, you can start projects that aren't going to get done in a year and know that you will be able to pursue them and continue them. And so since 2015, that has been the way in which the Congress has addressed NIH, and it has been phenomenal in terms of what it's made possible, the way it's allowed us to encourage new early stage investigators to come on board in greater numbers than ever, like twice as many early stage investigators as we had 5 years ago, and give them the confidence that there's going to be support for them to pursue their new innovative ideas, not just sort of the obvious next derivative question, but something that could be really groundbreaking. And that's what you want people to do. So coming back to messenger RNA, I think it's a great example of that. All the way back in 2004, investigators we were funding looking at the possibility of whether messenger RNA might potentially be used for a vaccine, got over what had otherwise been a major block. If you just inject normal messenger RNA like your cells are making right now as this sort of way in which DNA instructs the formation of protein, it's inflammatory. Your cells don't like having that stuck into them when they didn't make it themselves. But it turns out you can modify the messenger RNA with some simple chemical changes that still allows it to contain the appropriate coding information, but it doesn't have the inflammatory response. That was a pretty critical finding. And it's supported by a very basic science grant that a lot of people might have said, you know, why are you bothering to look at this? Building upon that, our own vaccine research center on the NIH campus, beginning 2013 and incredibly prescient in a certain way, began working on a messenger RNA vaccine for MERS, this other kind of a coronavirus, which is related to SARS-CoV-2, our current threat. And over the course of those years, worked out a lot of the particulars about how this could work, initially using a mouse model. And so when on January 10th, the sequence of that virus was posted by the Chinese, the folks in the Vaccine Research Center, building on all of that experience, the next day had designed the vaccine. And 2 days later had worked with Moderna, the biotechnology company, about how to synthesize it. And 63 days later, the first patient was getting injected for the phase 1 trial. That is about 5 times faster than a vaccine has ever gotten into human trials. And it was building on that remarkable trajectory of the preceding years. So how does it work? I mean, messenger RNA is basically the way that your cells take information in DNA and figure out how to make a protein. And the messenger RNA is just like it sounds. It's the messenger, it gets copied off the DNA strand, and then it goes to this part of the cell that does the translation, those wonderful ribosomes, and gets converted to a protein of a particular sequence. So of course, if you want to raise antibodies against this nasty virus, what you probably want to do is to figure out which part of the virus is going to be the most appropriate to get an antibody to. And it's these spike proteins on the surface. Those are the guys that if you had an antibody to them, it would sort of stick to the virus like chewing gum on this, and then it wouldn't be able to get into your cells. So let's make the messenger RNA that codes for that spike protein, doesn't code for the rest of the virus. So there's no risk here. You're going to actually give somebody COVID by injecting just the spike protein. And that's what you do. Inject that into muscle. The muscle cells go, oh, that's messenger RNA. We know what to do with that. Make the protein. The immune system goes, oh, that's not me. That's some foreign thing. I'd better make an antibody. And the good part of this also is the injection is short-lived. The messenger RNA is gone after a few hours. The spike protein is gone after a day or two. So there's no lingering consequence, but the immune system has been primed. And what we learned was that this works incredibly well.
Well, this is really important for folks to kind of understand the investment that was years in the making.
Yes.
And literally, that's why Warp Speed worked, because we invested those dollars way ahead of time trying to study, where at the time MERS was probably a really good, spurring, if you will, to do that.
And we didn't know that MERS might not turn out to be a big threat to the world. Fortunately, it has not burst forth from only a few places. And that was the concern when they started working on that. And nobody really knew it was going to be a different coronavirus in 2020. But it all builds upon itself. That's how science works. You invest in the basic efforts. One person learns from another, it gets better. And then all of a sudden, you've got a body of knowledge that can be brought to bear on a crisis.
Well, that's where, thank you, Senator Durbin, for investing in science. This is really, really cool to hear this story and this trajectory. I've got a practical question for you from the chat. Kids participating in the trials for vaccines. Your thoughts on that?
Well, as is always done when you have a completely new disease with a new approach, whether it's a treatment or a vaccine, the approach is to start first with adults. We think of kids as being somewhat more vulnerable, and you certainly don't want to take a chance until you have a little bit more experience. So the initial trials were only adults. The Pfizer trial has now extended that down to children at age 12. Moderna is talking about doing the same, so is Johnson & Johnson. And then once we have a better sense of how we're doing in adolescents, it'll be time to try it in younger children. I think this is the right way to go. It will have some consequences in terms of when the vaccines will be generally available to children. So it will lag behind where we are with adults. As you know, with adults, we are within potentially a couple of weeks of beginning to immunize the high-risk individuals and the healthcare providers. Children, it will turn out to be more like in the spring, just because we will need to run trials and make sure that they have the appropriate immune response and that it's safe.
Very good. We have a question in the chat about long-term side effects. I know you saw the media publish some sort of side effects reports. Any thoughts about any possibility of autoimmune issues or other long-term side effects? For those folks who are sort of weary of vaccines, this is the type of question is going to come up.
No, it's very important. And Dr. Whitaker, I think we're all concerned about the level of vaccine hesitancy that exists in the United States of America. That has been there before, particularly about such concerns about measles vaccine, which frankly are not founded on scientific data. But now here we have another vaccine about which there is less experience because this particular virus only appeared last January. The best we can do is to look at the data that has been accumulated by the phase 3 trials for Pfizer and Moderna, which together adds up to 60,000 people, and to say that there's no evidence of any surprising severe adverse events in the people that have been observed for at least 2 months who have received these vaccine injections. And there has not been. There is the usual kind of adverse events, which is your arm is sore. A few people sometimes get a little fever the next evening after the injection. Frankly, that basically tells you the immune system has recognized that something happened and it's making a response. There have not been any severe adverse events with either of these messenger RNA vaccines. And of course, I would love to say we now have 10 years of experience and there's been no long-term effect, but we don't have that data. People are still going to need to decide between the benefits and the risks. Is this something worth trying? And when you consider the benefits of saving potentially hundreds of thousands of lives, I hope most Americans will see that as a pretty compelling reason to adopt the small chance that there may be some long-term consequence of this vaccine in a rare person that we can't at the present time predict.
But and I think it's important, Doctor, to just emphasize that we will continue to collect safety data. We won't stop because we started distributing the vaccine. We will continue to look at this data every day, every week, every year, right? This will be an ongoing process for us as we assess the profile. But in 60,000 people, I think it's important to know that, to your point, we've done pretty good so far. And the worst thing for the most part is people's arm hurting after.
Yes.
So I do think we have to do some work on vaccine hesitancy, which is probably a whole nother conversation that we'd love to have you come back to, but let me ask you a few more questions. Talk a little bit about some of the kind of disparities pieces and anything that the NIH is doing and anything that you think we can do to help you as you attack that work.
I'm glad you're raising this because this is a very serious issue and one that needs every bit of attention and rigorous research that we can mount, and we are totally focused on trying to do our part there. We knew already that health disparities are a serious issue in the US. Your own research, Dr. Whitaker, focused on that, as I understand, for hypertension and diabetes. We know that those illnesses are inequitably distributed and the consequences have been unfriendly and unkind to some populations, particularly African Americans, Latinx, Native Americans, who suffer from some of these conditions at higher rates. By the way, everybody will think, oh, this is Collins. He's the guy who led the Genome Project. He's going to tell us that's all genetic. It's not. I think almost all of those health disparities are on the basis of difference in environmental exposures, in terms of social determinants of health, in terms of stress. And it's those things which are causing this kind of troubling health disparities that have been around for a while. And COVID-19 comes along and shines an incredibly distressing and bright light on that issue. When you look and see how those particular communities have been unduly burdened and hard hit by this virus, hospitalization rates for African Americans and Latinos 5 times what they are for white people, and death rates about twice. So we knew already we had health disparities, but many of those same conditions, hypertension, diabetes, are associated with a higher risk if you get infected with this nasty virus. And so it just multiplies. And we have every reason, therefore, to push as hard as we can, even more than we did before, on the health disparity issue. We have a whole institute at NIH, the National Institute of Minority Health and Health Disparities, led by Dr. Eliseo Perez-Stable. But I will tell you, every institute of the 27 at NIH is engaged in this. And we have a particularly intense internal effort going on right now to ask what more could we and should we be doing about health disparities, especially as we are in a year of recognizing the seriousness of racial inequities in health after the killing of George Floyd and a variety of other really troubling but maybe important moments for us to look at. What can we, NIH, do to look even deeper at the causes of health disparities, and not just catalog the causes, but begin to identify interventions that could be tested in a research study, and if they are then shown to be effective, promoted to apply in other places. One final thing I'll say in terms of a specific project that we're invested in, we're concerned that for COVID-19, many communities of color are getting hard hit and don't have the same access to testing that other communities do. And at this point, until the vaccines are out there in everybody's arms, which is months yet to come, having testing available for asymptomatic people to find out who's infected and give them a chance then to be isolated so that they're not contagious with others is the best way that we can keep the spread from getting even worse. And yet that kind of asymptomatic testing is not broadly available. So we funded a program called Rapid Acceleration of Diagnostics for Underserved Populations, $500 million. This was a congressional component of the CARES Act that Senator Durbin mentioned. And with that, we are aiming to try to get out there and have already funded about 40 different centers the opportunity to get more of these point of care tests that give you an answer in 15 or 30 minutes in communities where it could potentially be game changing. That's just getting started. We have those communities and those centers now funded, and they are going to be working hard to see if we could change the circumstances that so many of those communities are facing.
So, Dr. Collins, that's an amazing example of the entrepreneurial leadership at the NIH under your leadership. I actually was familiar with that effort, and you basically funded entrepreneurs who, got their tests perfected enough, had a high enough sensitivity and specificity, and turnaround time to be able to get out to communities, right? And that's actually really, really exciting. For me as an entrepreneur and as a scientist, when I saw that happening, it's important, and I think you're going to probably make the same point, that the vaccine itself, as we were saying, is going to kind of distribute in waves, right? And there will be there's time to it, right? We've just got to get it approved, and it's got to get out, it's got to get to communities. But along the way, we have to continue to test, mask, and keep our distance, right? Until we get to that percent of folks who are all kind of immunized, right? And we're probably a year out from that, right?
We, at the rate we are going, have some hopes that we might achieve immunization of, let's say, 80, 90% of the American population by this coming summer. A lot will depend, of course, on people's willingness to roll up their sleeves. Some of it will depend on the other vaccines that are still in the pipeline and have not yet reached the point of having their safety and efficacy evaluated. And there are 4 more of those. That would be Johnson & Johnson and AstraZeneca and Novavax and Sanofi GSK. We have high hopes for those as well. They use different technologies. They're not the messenger RNA versions. If all of those get approved, then our production of a lot of doses goes up accordingly, and we could potentially get to the point of full immunization even a little sooner. Right now, the capacity we will have in this month, if FDA approves the Pfizer and the Moderna applications, and those are going to be getting discussed in public meetings in the next 10 days, is about 40 million doses. I should say, by the way, that we wouldn't have any doses if it hadn't been for Operation Warp Speed, putting in place a plan to do manufacturing of vaccine doses even before we knew if the vaccine was going to work. We've never done that before, but it was a smart, albeit financially risky, step to take, because otherwise we could find ourselves in a circumstance of having a big celebration saying the vaccines work and then going, oh, but it's going to be 6 months before we can build a factory and have enough doses to help anybody.
Right.
So this at-risk manufacturing was part of the Warp Speed plan, which is now turning out to be pretty darn important. So those 40 million doses that will be available this month, if those 2 vaccines get approved, will need to be prioritized. And you probably saw earlier this week, the CDC's Advisory Committee on Immunization Practices recommended that first up should be healthcare providers who have direct contact with COVID patients, and those in residential settings, elderly folks in nursing homes and assisted living who are at very high risk, as we have seen from this illness. That will pretty much use up the doses that we have in December, but more will be coming in January, February, March. And we will have to go through this sort of list of priorities, and the CDC will continue to update those to get ultimately to everybody. And we mentioned children a little while ago, which will be late in the process because we still need to be sure the vaccine is safe and effective there. But if you look at that, I think June, July, we might be in a pretty good place if all this goes the way it's supposed to.
And then Dr. Collins, congregate settings. I mean, we haven't talked about prisons, but prisons are got to be close to nursing homes.
Obviously, very high risk areas indeed. And that is something I know that CDC will also be considering as they try to figure out what's their next set of recommendations. As of course, essential workers, people who can't afford to stay at home, like I'm here working in my home office, which I've been doing pretty much 100 hours a week since March, but a lot of people don't have the ability to be able to be safe and isolated like I am. Those folks who are running our essential economic businesses, the grocery stores and so on, they need to be pretty high on the list as well. As do, places like meatpacking plants, which we know can be a real difficult spot for the outbreaks that have vexed us already and might continue to. All of that has to be factored in there in order to have this turn out right. But I think the pieces are in place to try to make all that come to pass. But meanwhile, and you were going there, meanwhile, we have to recognize there are things we can all do. It breaks my heart that it's so hard to convince people about these issues because it's gotten so tangled up in conspiracy theories and politics. And a mask, which is basically a life-saving medical device. That's what I think of a mask as. Yeah, it's a life-saving medical device. Think of it that way. And yet for some people, it's a political statement or it's an invasion of your freedom. No, it's really not. It's basically you are trying to take some responsibility not to go out there and kill some people because you might be the person who's infected and you don't know it. If we could somehow, in this moment, hit the reset button on mask wearing and physical distancing and not congregating indoors in the most dangerous places, we could make a big difference. But that means we've got to convince a lot of people who are still pretty reluctant to buy into this. The evidence is overwhelming.
So Dr. Collins, I just want to, for our group, our audience, so NIH really, is running part of two parallel processes. If we were to have a national kind of policy right now, and this kind of thing would reset, right? Because things keep changing. One, we've got a vaccine online. We really want to convince as many folks as possible to take it, come up with a strategy to distribute, makes sense. We got that, but that's going. The other side is you're trying to fund point of care, rapid testing, and make it available in as many neighborhoods as you can, particularly where people are particularly impacted. So we'll continue to need to know COVID status, right? And we'll need to continue to mask up and protect ourselves as we run out to sort of distribution that gets us to 90% plus, right?
That's right.
So,
That's right.
so both processes are really important. And that really just applaud the NIH's work on this rapid testing. I think the University of Illinois Chicago has a rapid test, I believe, that's out. So we got some work going on here in Illinois that we're proud of around that as well.
Yeah, what's going on at UIUC, the way in which they are using this rapid test on their faculty and students is something the whole world is watching, by the way. I'm not sure that that's been as clear to you all as it is to us. We're actually partnering with the folks at Urbana-Champaign to try in that setting to see if we can even make this better by using some of these point of care so-called lateral flow assays and see if they'd be just as good as the somewhat more expensive RT-PCRs. But that's been an amazing example of entrepreneurial creative activities by a university. So hats off to UIUC. Can I bring up one other thing that I think people aren't aware of, just in terms of the importance right now of taking every possible action to limit new cases? And that is this increasing realization that COVID-19 sometimes is not a short-lived illness where you get it and you get better and 3 weeks later you're fine. We thought that ought to be the case. It's a respiratory virus. That's the way it is sort of with things like flu. But there's a significant proportion of people who have fallen ill with COVID-19 who weeks later are not back to normal. They're still short of breath. They're still fatigued. You do cardiac MRI scans and you can see their heart muscle is not normal yet. They have brain fog for reasons that were not entirely clear, but may have something to do with the very small blood clots that this virus likes to form all over the body. This, Senator, I'm bringing this also in front of some of the members of Congress because I'm really worried we may have what is emerging here as a long tail of consequences for this acute disease. If this is going to affect as many people as it might, we're going to have a chronic illness following the acute illness that is going to be extremely challenging to understand and to manage. And so we're feeling at NIH acute pressure now to try to put together a cohort of about 10,000 survivors and study them intensively to try to understand what is the basis of this so-called long hauler syndrome. That's what some people are calling it. And what could we do to treat it better or prevent it? But meanwhile, we want fewer people to get sick in the first place, because this is both alarming that it happens at all, but it's particularly alarming that it can happen to people who seem to have had pretty mild disease. They weren't in the hospital. They had a couple of days of fever and a cough, but then they don't get better. Yeah. And that is another reason I think we have to do everything we can to understand and prevent this illness as fast as we can.
You know, it might be your next Framingham, Doc.
Well, yeah, and it probably needs to be on that scale and all over the country. So we already are figuring out, well, after all, we've been running all these therapeutic trials for various interventions to help people who are sick. Let's be sure we follow those people and see what happens over the course of many months. And let's go to Framingham and say, okay, who at Framingham has gotten COVID? Because we have this background information on them. What happened before? What happened after? Is there some biomarker here that would tell you that this person was at risk for a longer term consequence? We have a lot of work to do there. And unfortunately, work that's going to be expensive, for which we didn't previously know we were going to need the funds. So I'm hoping we can figure out some way to cover this. This is going to be really important.
Makes me want to come back to research, Doc.
Hey, come on, we got room for you. Sorry.
So look, we got a few questions in the chat. Let's try to get to see a few of them here. Let's see. This question is, how often we'll have to take the new vaccine? For the mRNA vaccines, you know, I've seen that it's probably a couple of doses, 30, 45 days apart. For the adeno vaccines and the other formats, any ideas? Share with us what you will.
So all of the 6 vaccines that are under intense study in the US require 2 doses, except for one. The Johnson & Johnson vaccine is a single dose. And obviously people would probably be happier if they didn't have to come back in a month for that sort of month-long booster. But in order to get a really good immune response, the others seem to require that. So that's going to be a deal as we are issuing the opportunities for people to get vaccinated. You want to be sure you don't lose them before they get that second dose for the full effect. And you want to be sure they get the second dose of the same vaccine they had the first time. So there's some logistics and record keeping there that is being attended to. I think the question also is how long does the immunity last after you've had the vaccine?
Yes, that's a question.
Everybody wants to know that. And at the moment, it's pretty hard to give a clear answer because we haven't had the experience long enough. It is pretty clear that people who had infections from COVID-19 rarely get reinfected. There are maybe 4 cases that I kind of believe where somebody had it and then a few months later got exposed again and got sick, usually not very sick. But the fact that it is that rare tells you that natural immunity after infection is probably pretty good. And you would like to think, therefore, that immunity after vaccines are also going to last for many months. But we don't know. Is that going to be something that will require another booster in a few years? Will it be like your tetanus shot where, every 10 years you really ought to get re-immunized? Or if we were really lucky, would it be like measles, where you've had that measles vaccine, you're protected for life. You don't need that one again. And again, we don't know. This is going to take a lot more science, a lot more follow-up.
Sensitivity and specificity of the rapid test that we were talking about, the point of care test. Any thoughts there? Like, is there, for example, do you make sure there's a certain threshold before you will approve one being distributed as an example?
Well, what a great question. And of course, it's FDA's job to look at that and decide whether to issue an emergency use authorization for a particular point of care test. And they do this very carefully, and they have set certain standards. Most of the point of care tests utilize what's called an antigen approach. They're not measuring the actual RNA, the nucleic acid, because that requires a more complex apparatus that doesn't really work very well in a point of care with a few exceptions. So they're actually looking for the protein that's in the virus. So this is basically one big protein. Try to figure out in a nasal swab, is there evidence that protein is there with a lateral flow assay? But they're getting pretty good. A number of these now have sensitivities approaching 90% and specificities likewise. And that's not much worse than what you'd get. In fact, I will even say there are people who would argue, like Michael Mina at Harvard, that they may be actually more appropriate for detecting somebody who's actually contagious. The methods that detect the RNA are maybe even a little too sensitive in that they will actually be positive in somebody who's had COVID-19 and will stay positive sometimes for 3 or 4 weeks when they've all recovered because there's still fragments of that RNA floating around, even though there's no intact virus. The antigen tests seem, if they're positive, you're probably contagious. The false negatives, therefore, are probably not as serious as they might initially have seemed. But all that needs to be tested. One of the things that I'm working on very hard right now, with a lot of help from the folks who've been running this RADx program, the Rapid Acceleration of Diagnostics, is home testing. Imagine having that as a capability. Where you have in your own house.
Yeah, I was going to ask you, is this something that we will be able to pick up from the drugstore?
That's what I would like. I mean, FDA has approved one such home test. It requires a prescription from a company called Lucira. It's pretty expensive. It's not the sort of thing that most people would want to do a couple times a week. So we're working on much cheaper ones, and they're simpler ones as well, and wouldn't require a prescription. And what I'd like to do is to try that out in a few carefully chosen communities and see, could you show that if the whole community was doing home testing, that the number of cases went down and went down pretty quickly? If we could show that, then maybe people like Senator Durbin would agree, then we ought to have the whole country start doing home testing and figure out how to pay for it, because that could be our greatest hope for really dropping the incidence. So
Doc, we've got about 8 minutes left, and I got a couple of great questions I definitely want to ask here, so bear with me. And this really kind of dovetails into what you were just talking about. accessibility. One of Alan Rosenberg asked, given the increased funding for NIH research, and basically how much are we talking about for warp speed support? Was it over 18 billion or 40 billion? I can't remember. But was it, how much was it?
Yeah, of course, that didn't all go to NIH. Let me be clear
Oh, I
about
know.
that. A lot of that's
We know.
manufacturing.
Exactly. It went to places like Pfizer, Moderna, et cetera. And one of the questions is, has there been any consideration in placing restrictions on the pricing of these by entities that would help the affordability more broadly of treatments? And I think that would include some of the antibody therapies and other things that are coming out, right?
Yes.
That will help diminish both disparities and pressures on state budgets. So let me just give you a blatant example. The leader of our country got whatever was available, wasn't quite approved yet, the libido cab, one of those things, right? But on the South side at Roseland, that person didn't get that. So knowing that warp speed helped to really bring a lot of this stuff to fruition faster, what should we be doing to help broaden the affordability and accessibility of these types of treatments?
So that is a really important question, and the warp speed effort considered that, I think, in a very positive way. So one of the things warp speed has been able to do is to basically buy, with those $10 billion plus dollars, large numbers of doses of vaccines and of monoclonal antibody therapeutics, so that they don't have to be paid for by the patient once they're approved by the FDA. So for instance, you mentioned monoclonals. There are two companies, Lilly and Regeneron, that have had their monoclonal antibodies emergency use authorization from FDA. And I want people to start using those. They work as outpatients. You need to get it early. It doesn't seem to help very much once you're in the hospital and you're really sick. But if you could get this monoclonal antibody within 72 hours of diagnosis, if you're a high-risk person, it could really change things. It won't cost for the antibody. They'll still probably charge you for the infusion capability. And that's where third parties like Medicare and Medicaid come in. And I know CMS has been working really hard to figure out how to cover that as well, because these are infusions and a lot of people don't want to have to go to the hospital to get this done. Can you have this done in a clinic? Can you call that the equivalent of a hospital? CMA has been working pretty hard on that. So yeah, I'm glad you raised it. I think it is a topic of great interest and concern. Ditto with the vaccines. The government has bought tens of millions of doses, so they don't have to be paid for. You may still find the person who's doing the injection wants a charge for their medical service, but the vaccine itself will be free.
Dr. Francis from Erie Family Community Health Centers and FQHC, you have any thoughts on the role of community health centers in NIH research regarding COVID, even if we were to think about, for example, like a large sort of Framingham style trial, and also with distributing the vaccine? Any thoughts there, Doc?
You're asking, I'm sorry, I didn't quite understand the
role of community health centers
yes.
in NIH research regarding COVID-19 and the role of community health centers in distributing the vaccine.
Very, very important. And we have been working personally with all of the companies that are doing the trials to try to be sure that their enrollment reaches out through community health centers and other mechanisms to enroll people of diverse perspectives. And that has gone reasonably well. And certainly when it comes to the distribution, that's where a lot of high-risk individuals are going to get their care. The states are going to decide, once CDC kind of lays out this list of priorities and the states get their shipment of vaccines for that week, they're going to figure out how best to allocate it. I certainly hope every state will be thinking closely about how to integrate such places as the community health centers as a wonderful way to do that distribution. I know many of them are thinking about that. I don't know about Illinois, but I would bet Illinois, being a pretty forward-looking part of the country, would have considered that already.
Dr. Whitaker?
Yes.
I wonder if I could ask a question.
Yes.
I have so many questions I'd like to ask. I'd like to know about the Russian vaccine, and I'd like to know what warp speed 2 will be, if there should be, after we put, God willing, this terrible virus behind us. But I guess I'm going to ask a more practical question. While we're in the process of vaccination, and there are people who win the vaccination lottery or the vaccine volunteers, and we're starting to get the critical mass and such, is the lifestyle of America going to start to change at that point? Will there be a moment where we get a 2-minute warning that we're close to the magic number for the immunity? Will the numbers tell us that story? And will there be a whistle we can wait for in the near future that says, let's get on with America as we once knew it?
And won't that be a grand moment indeed?
I know, right?
That's a great question, Senator, in terms of when will it be safe to take the mask off and stop worrying about not being able to hug people. I really miss a lot of those moments where we can be with each other, and it'll be wonderful to go back to life that way. It's going to really depend on watching how we do, and it won't necessarily be the same in every setting. I think if we get to a place where there are particular environments that have gotten pretty well immunized, so for instance, maybe nursing homes will actually be one of the safest places to be in another couple of months. But in schools, perhaps if we can get kids immunized, it would be wonderful for kids.
Teachers,
Yes. Yeah, they're
Teachers.
essential workers. So yeah, we got to get them high on the list as well. But over the course of the coming months, it'll be probably not a 2-minute warning in one place. It'll be a gradual setup. Okay, we should now have reached the point where it is safe to start going back to life as usual. And I'm really hopeful, and it's not just hope based on hand waving. I think it's based on the science we have that by June or July, I might be able to go to a baseball game and not worry about the fact that the stadium is full, because I love that and I've missed that.
Dr. Collins, we've got 2 minutes. I did not know. I got to ask you one question that we got to summarize. Okay, we've got so many questions on the chat that we're not going to be able to get to. So I apologize to our listeners and appreciate all of you for being on. Firearms violence. You've got money for that at the NIH. Just give us a quick nugget on that. We've got we got about 60 seconds.
Okay, quick nugget. We have been doing research on firearms violence all along, and we were given a special boost of $12.5 million recently by the Congress. We are looking for really good projects. I will tell you, we have not had as many as I would like coming to us. So if you have people in Chicago who are designing interventions that you want to work with a researcher to actually document how they work and then extrapolate to other places, we'd like to hear from you, because I think a lot of the research right now is still kind of calculating on factors and not looking at interventions to make it better.
Dr. Collins, how do we bring science back?
Well, I think science has basically proven itself this year as one of the places that's going to get us through a terrible time. A lot of young people are noticing this, and I hope a lot of them are going to come join us, because this is kind of like Sputnik, only in a very different way. Like, oh, wow, we need science, and science is exciting, and science can actually do things in this instance, like save hundreds of thousands of lives. So I think science is coming back, and I hope people will see that as something they want to be part of.
Senator Durbin, any closing remarks?
No, I think we realize we have a national treasure visiting with us today, Dr. Collins. I'll say it, you would never say it, but we are fortunate that presidents of both political parties believe this man has made a difference time and again in the history of the United States. May you live a long life and as productive and as good as it's been so far. I hope it's even better in the future.
Oh, thank you, my friend. And it's wonderful being able to work with you across these years and to see these kinds of things come forward. You've been a real champion. No one is a better supporter of NIH in the United States Congress than Senator Dick Durbin.
That is a good opening line for my obituary.
Senator Collins, really our pleasure today. Just really honored. Thank you.
Thank you all very much. Thank you, Dr. Whitaker.
Thank you. And thank you to the Institute of Medicine for the over 150 of you who joined us today. This was really a lot of fun. Science is back. We're all excited. Bipartisanship is back. We're excited about that. Thank you, Senator Durbin. Everyone, have a great, great day. We're going to run a few slides thanking our healthcare workers, but we understand that folks have to get on to their next commitment. So just really grateful to everyone. Thank you to all of our healthcare heroes. You'll see some photos going along. I know I have friends who've been working this for the last several months. They're exhausted, but they're committed. And we want to thank all of them, nurses, doctors, respiratory therapists, janitors, frontline workers in the hospitals, intake, bus drivers, people working at the grocery store, dentists. We want to thank all of you for the work that you've done in 2020 to keep us all safe. So everyone have a great December. We're looking forward to bipartisanship. We're looking forward to science coming back. And we thank all of you. We're looking to continue to work together as we approach 2020 and beyond. Thanks, everybody.